Good evening, and welcome to AUA's Contemporary Management of MIBC and Beyond, Expert Guidance for APP's live virtual course. We strive to offer outstanding educational courses and greatly appreciate your evaluations and general feedback so that we can continuously improve our programs. The AUA is accredited by the ACCME and designates this live activity for a maximum of 1.5 AMA PRA Category 1 credits. A course handout from the presentation has been made available to you. Please visit AUA University to access the handout. Evaluations are very important to us. Course evaluations and CME credit will be administered electronically on the AUA University immediately following the course. As we at the AUA continue to develop virtual education that meets your needs, we especially welcome your feedback regarding both the content and format following this program. Please stay tuned for a keyword that will be provided at the end of the webinar. The keyword is used to verify your participation in the webinar. You will need to use this keyword to access the course evaluation, CME credit claim, and certificate. All persons in a position to control the content of a CME activity are required to disclose to the AUA as the ACCME accredited provider all financial relationships with any ineligible company, formerly commercial interests, during the last 24 months. An ineligible company is defined as one whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. The AUA must determine if the individual's relationships are relevant to the educational content and mitigate any conflicts of interest prior to the commencement of the educational activity. The intent of this disclosure is not to prevent individuals with relevant financial relationships from participating, but rather to provide learners with information so that they can make their own judgments. Coding advice given during this presentation are the opinions of the presenters and may not have been vetted through the AUA for accuracy. Please verify accuracy prior to reporting on medical claims. You are prohibited from using or uploading content you access through this activity into external applications, bots, softwares, or websites, including those using artificial intelligence technologies and infrastructure, including deep learning, machine learning, and large language models and generative AI. The AUA would like to thank Astellas and Pfizer, Inc. for providing an independent educational grant in support of these activities. Finally, I'd like to introduce and extend a special thank you to our course director, Dr. Adele Caruso, for her time, talent, and expertise in developing this program. Dr. Caruso is an advanced practice provider at Penn Medicine with a special practice interest in urologic oncology, bladder, renal, prostate cancers, and adjunct assistant professor at the University of Pennsylvania School of Nursing. She received her bachelor's degree from Villanova University, master's degree from the University of Pennsylvania, and Doctor of Nursing practice degree from Vanderbilt University. Dr. Caruso is recognized for her expertise in health policy and pivotal contributions for advancing Pennsylvania's legislative efforts to remove barriers for NP practice and improve access to quality healthcare. In June of 2020, she was inducted into the Distinguished Fellowship of the American Association of Nurse Practitioners, reserved for those individuals who have made significant contributions towards the global advancements of the NP profession. She is an active member of the AUA and the Mid-Atlantic section of AUA. I will now turn the course over to Dr. Caruso.
Hello, everyone. Thank you all for joining this evening to participate in the AUA's program, Contemporary Management of Muscle-Invasive Bladder Cancer and Beyond, Expert Guidance for Advanced Practice Providers. Our activity goals based on the documented need from the AUA Advanced Bladder Cancer Global Needs Assessment. The AUA is offering education to update advanced practice providers on the latest advancements in muscle-invasive bladder cancer treatment. Learning objectives. So you may read these objectives on your own, but after participating in this CME, we're hoping that you will achieve all of these at the conclusion of the course. At this time, it is my pleasure to introduce the faculty. These are subject matter experts joining us this evening. First, we have Dr. Trinity Bevilacqua. He is a board-certified urologist with training and expertise in urologic cancers and sexual dysfunction. He is the director of urologic oncology and co-director of the genitourinary cancer service line in the Abramson Cancer Center at Penn Medicine. His specialties include the surgical management of prostate, bladder, penile, and upper tract urothelial cancers. Dr. Bevilacqua has expertise in open, endoscopic, laparoscopic, and robotic surgery, and is equipped to individualize treatment options for patients with a wide range of genitourinary malignancies. Next, we have Dr. Kristen Farling, a certified urologic nurse practitioner and assistant in urology at Johns Hopkins Hospital. She obtained her BSN, MSN, and Doctor of Nursing practice degrees from the University of Maryland, Baltimore, with a focus on survivorship needs of prostate and bladder cancer patients, specifically sexual recovery, intimacy, and urinary incontinence. And finally, we have Mrs. Colleen Tetzloff, a physician assistant at Fox Chase Cancer Center in Philadelphia, PA. She specializes in GU medical oncology, where she provides compassionate, evidence-based care to patients with prostate, kidney, bladder, penile, adrenal, and testicular cancers. She is a former president of the Association of Physician Assistants in Oncology and on the current planning committee, member for BCAN, the Bladder Cancer Advocacy Network, Walk to End Bladder Cancer in Philadelphia. So let's start by discussing our questions in our first segment. And our first segment is labeled Diagnostics and Staging. So let's get started. I will address Trinity. And the first scenario for discussion is a 55-year-old patient who presents for discussion regarding cystectomy and urinary diversion. Upon pathology review, he was found to have disease within the prostatic urethra. What type of diversion would you offer him?
Thanks, Adele, and congratulations on the course. This is a question that I'm so happy that you brought this up as the first one. It's a lot to unravel with this. So I think the best place to sort of start is that if you have a patient with muscle invasive bladder cancer, I'd like to sort of just briefly discuss what their options are. You've alluded that one of the options is a cystectomy. However, there is an alternative to that in select patients with muscle invasive disease, which is called trimodal therapy, which is where you would undergo a re-resection and then chemotherapy followed with concomitant radiotherapy. If this patient, as you pointed out, has involvement of the prostatic urethra, then they would not be a candidate for trimodal therapy. So they're ideally set up for a radical cystectomy with urinary reconstruction. So we're going to have lots of discussion later, and I'll let my colleagues comment to this, but in my practice, if the patient is platinum eligible, I'm referring to get cisplatin-based chemotherapy, and I'm obviously happy to discuss that further, but I think this question is really related to, with a patient with prostatic urethral involvement and muscle invasive disease. So ideally, they've received their chemotherapy. They're then followed back up with urology to discuss surgery. If you're thinking about different urinary diversion or reconstruction options, as you are well aware, as probably as others are, is that there's 3 options for diversion. We bucket them into sort of two buckets: an incontinent diversion and then continent diversions. So incontinent means that's the ileal conduit or urostomy, which is the most common urinary diversion. 9 out of 10 men and women in the United States today, if they are going to undergo cystectomy, are going to get an ileal conduit or incontinent diversion, which is where we use a piece of their intestines to connect the ureters to and bring it out to the outside as an appliance, or patients call it their bag. However, there are select patients. These are typically patients that are younger and a little bit more robust that are interested in a continent diversion. The most common continent diversion is something called an ileoorthotopic neobladder, which is where we use a piece of the intestines and we're able to make them a quote unquote new bladder. Now, the question here revolves around, is a patient who's interested in a continent diversion, are they a candidate for a neobladder with prostatic urethral involvement? In my clinical practice, that is not a problem whatsoever. I do not, that is not a contraindication. I'll be honest with you, my only contraindication for a neobladder in my practice is if they have renal insufficiency, because continent diversions really, in particular conduits, neobladders, really have long-term effects on urinary, on upper tract deterioration. So if you've got a patient with a GFR less than 30, I'm very hesitant to give them a neobladder. This patient likely has good renal function, so there is zero data in the literature to suggest that a continent diversion is contraindicated with someone with prostatic urethral involvement. In my practice, I don't even obtain frozen margins at the time to look at the prostatic urethra, because once again, there's very little data in the literature to suggest that that is going to prevent or that those patients are at higher risk of developing a local recurrence in the urethra. What a prostatic urethral involvement does suggest, that means they have higher stage cancer. They're at least, if they're in the new grading system, they're T2 or higher after chemo, they're more likely to relapse distantly. So they're going to have metastatic or relapse, not local. So in my practice, I still offer those patients a neobladder.
Great, thank you. You asked for challenging questions, so I hope that met the criteria. So our second scenario, a 70-year-old patient with high-grade T1 urothelial cell cancer undergoes a restaging TURBT, which demonstrates high-grade T1 disease, no CIS, and the absence of muscle in the specimen. What would be your next step?
Yeah, so the AUA guidelines clearly state that all patients, so it says you should, not you can or you may, you should perform what's called a restaging TURBT, or transurethral resection. And the purpose of that is actually threefold, because we know that in patients with high-grade T1 disease that undergo a restaging exam, 50% of the time you'll find residual disease. And actually, if there's muscle in the specimen and they have T1 disease, the chances of them being upstaged to T2 is less than 10%. However, if the patient has T1 disease with no muscle in the specimen, then when you bring that patient to restaging TUR, we know that about 15 to 20% you'll find muscle invasive disease. So the purpose of a restaging exam is to remove any residual microscopic disease, non-invasive disease, and to do, to the best of our ability, accurately stage their cancer. The last reason to do this is that we know that all intravesical agents for the treatment of non-muscle invasive disease are most effective if there's no papillary disease present. So that's why we perform a restaging in all patients with high-grade T1.
Great, thank you. So our second question is for Kristen, and the question is, a known bladder cancer patient returns to you in the office following post-treatment TURBT. The pathology shows disease progression to muscle invasive disease. As a urology advanced practice provider, how would you counsel them regarding their next step?
So when a patient comes in and now they've had the pathology shows that the cancer is involved into the muscle, we have many different treatment options for the patient. And we also have to tell them that now we actually have to think about removing the bladder. And that's a scary thing to talk about with the patient, is that now that that bladder cancer is involved in the muscle, we can no longer do these TURBTs to get rid of the cancer. We actually have to now do more invasive treatment. And some things we need to think about is, if they haven't already had it done, is had they have a CT scan beforehand. You know, doing a CT scan, chest, abdomen, pelvis, is there any kind of cancer throughout that we didn't know about? And then figuring out what are the options for these patients. You know, standard of care is going to be neoadjuvant chemotherapy, like Trinity talked about, with cisplatin-based chemotherapy, followed by a cystectomy. But then we had to think about, okay, what is this patient's performance status? You know, do they have renal insufficiency? Do they have hearing problems? Do they have problems with neuropathy? You know, are they eligible for cisplatin? So kind of giving them some ideas of what to expect whenever they do see the surgeon to go over these different things. You know, we want to kind of present them all the information so they have the knowledge whenever they do see the surgeon of what my options are. Then we think about, okay, cystectomy. Cystectomy is going to be an option for these patients. Then how do they get rid of the urine? And these patients might be very concerned and scared about that. And we need to let them know that we have lots of options. They could be the ileal conduit, like Trinity talked about. That is a incontinent stoma. There's a stoma that's placed. There's an ostomy bag. So they constantly have urine that goes into that bag, but they do have an external appliance that they have to be aware of. Maybe they're young. Maybe they don't want to have an external appliance. So then we talk about the continent urinary diversions, like the Indiana pouch or things of that nature, where we make a pouch and then they actually catheterize themselves a few times a day to give them that freedom, give them that little bit of just some different options or different freedom from not having to have that external appliance bag. And then you also have the neobladder that was just also referred to. These are patients who now are able to voluntarily urinate through the urethra. So these are all different options that patients may or may not be candidates for. And when we're thinking about what these options are, if they're having the continent catheterizable diversion, what's their mental acuity? What's their dexterity like? Are they going to remember to do these catheterizations? Are they going to have the hand skill coordination to do it? So all those things play a part in talking about these options for patients. And then some patients may not want to have their bladders removed. And we have to think about, are they candidate for the trimodal therapy, which would be an extensive TURBT followed by chemoradiation. So these are some things to bring to the patient's attention. Now that the cancer is involved in the muscle, we have to actually remove the bladder. That's our conversation. What are they eligible for chemotherapy? And then how are they going to actually remove the urine, whether it be with a stoma, whether it be with a continent catheterizable stoma, a neobladder, et cetera. So these are the things I would present them with. It's going to be overwhelming to the patient, but trying to give them these options so when they do see the urologist, they'll be a little bit more prepared.
Great answer. Thank you. Our next question is for Colleen. Colleen, what constitutes high-grade T1 disease and what distinguishes it from T2 disease?
Yeah, thanks, Dr. Caruso. I think before we even address like the high grade, it's important to go back and distinguish between T1 and T2. So wanted to put this important slide up just as a reminder. T1 is the cancer invading into the lamina propria, or the layer, the connective tissue layer underneath the bladder lining. But T2 is the cancer invading further deeper into the muscularis propria, so muscle invasive bladder cancer. So T1 still considered non-muscle invasive, but T2 muscle invasive cancer. And then addressing the grade of really describes the cancer cell. And so the higher the grade, the less the tumor really looks like a normal cell. So that usually the higher the grade usually means it's more aggressive or behaves with like a potential to grow more quickly or spread. So these high-grade T1, although non-muscle invasive, they're really the most aggressive of the non-muscle invasive bladder cancer. Typically, even following transurethral resection of the tumor alone, these high-grade T1, they have about a 70 to 80% chance of recurring and about a 35 to 50% chance of progressing into muscle invasive disease.
A nice graphic. I think it really, gives us a good visual. Okay, so at this point, I think we should move along to our second segment, and the second segment includes side effects. So our first question is for Trinity. During your preoperative discussion, when you present surgical options to your patients, how do you address the side effects of treatment? And the second part of this question is, can you specifically discuss management of sexual dysfunction?
This is a conversation that actually starts on that first visit, but I intentionally meet with my, in particular, cystectomy patients on multiple occasions to have iterative conversations about what to expect following cystectomy. And that's important because it is absolutely overwhelming. Kristen was talking about how overwhelmed these patients are, especially the first time you meet with them. So I build into my practice at least 3 visits, and I know this sounds excessive, but at least 3 visits prior to chemotherapy, following chemotherapy, and then one more time before surgery. And my entire discussion with them, and this is for both men and women, is what to expect post-cystectomy. And I break it down into kind of 3 different categories. The first is infectious. So the most common risk is infection, and that it could be an infection of the urinary system, the GI system, surgical site infection, pneumonia, and the like. The second most common is problems with GI tract disturbance. As most people are aware, patients will have problems with what's called ileus, where the bowels just essentially are paralyzed. Small bowel obstructions are less common these days. It's going to happen less than 5% of the time in the cystectomies. And the last is revolves around the urinary reconstruction, right? So ureteral strictures, problems with urinary leak, incontinence, if you have a neobladder, problems with catheterizing, once again, as Kristen's commented, this is the conversation that you're having. But one of the things that I think does not happen for cystectomy patients, and we just presented this at the SUO last week, that cystectomy patients, because they're older, as you know, the average age of someone undergoing a cystectomy is in their early 70s. Oftentimes, we are not counseling them about sexual recovery or return of erections if you're a male, or problems, or if you're a female, having issues with return of orgasm, dyspareunia, and lubrication. So this is a conversation that I have with my patients prior to surgery as well as post-surgery. And I think we need to be able to offer our patients, male patients, nerve-sparing operation, and if it's a female patient, reproductive organ sparing operations with nerve sparing in order to preserve their quality of life. So that's a big part of my practice, and manage that both pre as well as post-operatively.
Great, thank you. So our second question is for Kristen. Kristen, can you discuss the role of neoadjuvant chemotherapy for muscle-invasive bladder cancer patients prior to cystectomy, and when caring for a muscle-invasive bladder cancer patient, how do you address common symptoms of fatigue, anemia, and neuropathy?
I think that one was actually for me, since I'm the
okay.
onc here.
Oh, absolutely.
No,
Colleen.
that's
Yep,
okay.
you're right.
That's okay. Medical oncology, so we get this. So yes, I think as Trinity and Kristen already alluded to, patients with muscle-invasive bladder cancer, not metastatic and eligible for cisplatin chemotherapy, should see medical oncology just to discuss neoadjuvant chemotherapy with cisplatin-based regimens. many clinical trials were done, and a meta-analysis of these trials showed that there is a statistically significant benefit for these patients, about a 5% improvement in overall survival at 5 years and a 9% improvement in disease-free survival at 5 years. So anyone, cisplatin eligible with non-metastatic disease, we should see the recommended regimen is dose-dense MVAC, which is methotrexate, vinblastine, adriamycin, and high-dose cisplatin. This is typically given once every 14 days for 3 cycles, can give 3 to 6. We typically at Fox Chase give 3 cycles, so they're typically done with their neoadjuvant portion of chemo in 6 weeks. The other recommended regimen would be cisplatin and gemcitabine. This regimen is given for 4 cycles, typically once every 21 to 28 days. So the minimum kind of time frame for a patient to be done with their neoadjuvant chemotherapy on cisgem is 12 weeks. That isn't to say that the regimen isn't difficult. It is high-dose cisplatin, so it can be highly emetogenic, but we do have really good medications now, a lot of our antiemetics. So I would say, fortunately, our patients don't have a lot of nausea and really rarely have any vomiting, so that's good. Do educate them. It can be quite fatiguing, particularly the first week after treatment, like days 3 to 5. But usually the second week, they usually feel better. However, then they have to kind of come back and do it all again. But do kind of reiterate to them that it is temporary, so it will improve once they can complete their treatment. Of course, it is high dose cisplatin, so you have to be sensitive to anyone who has any pre-existing neuropathy. You want to really understand what their baseline is and how severe it is. Typically mild we can get away with, but you're always asking, I kind of always ask patients, numbness, tingling, fingers, toes. Again, we're willing to tolerate some minimal, some intermittent, mild symptoms. But if it's interfering with their activities of daily living, ability to pick up items, buttons, things like that. Other things we're sensitive to is it can cause some hearing loss or tinnitus. Cytopenias for sure. Both of these regimens are given with growth factor support. So we're really supportive of them kind of through the treatment. In general, most do, really well, but not without saying that, it can be a more challenging or rough 6 weeks, but we get them through.
Great. Thanks, Colleen. And now the question for Kristen. Okay. Can you share with the audience the surveillance protocols for muscle-invasive bladder cancer according to the AUA guidelines?
Yeah, the AUA guidelines are fantastic. If you haven't seen them or you haven't had the opportunity to maybe not read the whole guidelines, but look at the algorithm, it really just puts things in a nice perspective. It allows someone who's either new to urology or someone who doesn't do bladder cancer often a nice framework of how to surveillance your patients. So we are going to be looking at the pathology stage, and they categorize it, if it's P2, P3, things of that nature, and where to start with your patient. And typically, you're going to do a CT scan, chest, abdomen, and pelvis every 6 to 12 months for 2 to 3 years. Then annually, you want to do blood work. Typically, it's going to be a CBC, CMP, along with B12 every 3 to 6 months for 2 to 3 years, then annually. And we think about, CBC is pretty normal, the CMP, because we want to make sure that their creatinines are fine. Trinity had mentioned earlier about they can be at risk for renal insufficiency, making sure that their creatinine level's fine, and also making sure that their electrolytes are fine, because we are taking part of that intestines to create this new pouch for them, making sure their vitamin B12 is okay, making sure they're not acidotic. We don't want to have them increase risk for like osteoporosis or osteopenia as they're aging. So these are some of the labs and why we're checking on these patients. And then looking at these intervals and following them on these intervals just makes it very simple. It makes it very manageable for patients. Even if you're able to give them these guidelines and say, listen, this is why we're doing it, this is the frequency of it, and it gives them some ownership of their survivorship or their surveillance as well. So the AUA guidelines are very, very helpful. It's just taking a picture of it or reading it, but I follow them and it's very simple. So hopefully this was helpful to you guys to understand that surveillance as well.
Oh, great. Thank you. Since we have a few minutes, I'd like to ask you another question, Kristen. So if the cystectomy patient returns for their routine biannual surveillance visit and they're concerned about frequent urinary tract infections, how do you counsel them and what strategies or therapeutics do you employ?
Oh, goodness. That's a lot, right? You know, these patients who are coming in with they're having recurrent urinary tract infections, I think sometimes we're trying to find out for sure, you know, what are their symptoms? You know, are they truly having urinary tract infections, or are they going to their primary care doctor and they're doing a urinalysis for some reason and it's showing bacteria, but they're not having any symptoms. So we kind of have to distinguish between either asymptomatic bacteria versus actually having symptoms. And symptoms would be, you know, fever, chills, back pain, maybe having some hematuria, seeing how they're feeling. Sometimes patients just feel odd. You know, they don't really know how they're feeling, but they just don't feel right. And that could also be a sign that they may have a urinary tract infection. And also looking at, you know, where the sample was obtained from. You know, was it a sample that was obtained from the catheterizable, or rather from the ostomy bag? You know, that is going to show colonization, or it's going to show contamination rather. So we don't want to look at that. That's just going to give us information that's not going to be helpful at all for us. So when someone's coming in with those questions or those concerns about a frequent urinary tract infection, first of all, find out, is it truly symptomatic and are they actually having infections? Second of all, where was the sample obtained from? If it's obtained from the ostomy bag, we really would need to repeat that by either putting on a new appliance and getting a specimen from the new appliance, or if we have the ability to do a red rubber catheter, just put a little catheter into the stoma and actually get urine that way. So we know we're getting urine right from the source. Another thing to think about is if these are neobladder patients. You know, neobladder patients a lot of times are unable to empty out their bladders all the way, and they may be having some retained urine. And then that retained urine is going to be a nice, you know, wet, warm reservoir for bacteria to grow. In addition to them having this intestines that has some, you know, bacteria already that they might be colonized in. So if they're a neobladder patient, you know, doing a post-void residual, making sure that they are emptying out their bladder, making sure that they maybe don't need to be doing CIC or clean intermittent catheterization. And then also finding out, is there any risk factors that we don't know about? Maybe they're diabetic and their sugar levels are out of control. Maybe they have a history of kidney stones, and maybe they have stones. Maybe we need to do a sonogram, or maybe we need to do a CT scan. Is there another nidus that might be possible that's giving them these infections? And then also could be able to tell us if there's any kind of anatomical structural differences that may be increasing their risk for infections. So there's a lot to think about when someone's coming in with these symptoms, but we definitely want to treat infections if they're having infections, because we ultimately want to preserve those kidneys. We don't want to have pyelonephritis. We don't want to have any kind of kidney damage. So we do want to treat them if they really are having infections, but we want to be well-rounded. We want to be well thought out whenever we are seeing these patients who are coming in with repeated infections.
Great, thank you. So we're now up to segment 3, which includes supportive care strategies. Our first question is for Trinity. Trinity, what do you think the role of a urologic oncologist is in patients treated for muscle-invasive disease who then demonstrate disease progression?
Yeah, this is a great question, and I think it's probably the answer to this question is probably very different depending on the individual. I will say that in my practice, I work very closely with medical oncology. I mean, they're my partner. I don't consider them anything but a partner. I mean, I call them that to the patients, so the patients know that it's essentially a team of oncologists or cancer docs that are taking care of you. So when I see patients, you know, once again, I know we keep talking about neoadjuvant chemotherapy, cystectomy. Even if I see a patient that had non-invasive disease that we did a cystectomy on and found more advanced disease, and as you're describing progression, lymph node positive or high stage, ultimately the person that's talking to them about their pathology after cystectomy is me. And I'm actually giving them recommendations for what I think would be the best option for them in the quote unquote adjuvant setting. And I think it's important as urologic oncologists that we are aware of all the landmark trials that I suspect Colleen and others are going to talk to you about, where we're aware of what's available for our patients. What is the data to support, for example, antibody conjugate combined with immunotherapy? As far as I'm concerned, EV Pembro is now the way that we treat metastatic disease, not chemotherapy. The role of adjuvant immunotherapy, the role of neoadjuvant cisplatin-based chemotherapy combined with immunotherapy, durvalumab, So we have to be aware of what the data suggests and what the data what the data shows that will best treat our patient. This is my patient. This is the patient I am fortunate enough to share with my medical oncologist. So I'm actually recommending. Now, ultimately, I tell them, however, I defer to my colleagues in medical oncology. They're the ones that are going to be giving you the medication, the systemic medication. So ultimately, that's a decision that you're going to have to make with them. So in my practice, I'm intimately involved and also involved. A lot of my colleagues in medical oncology, I'll follow them with their scans. For example, if they have a neobladder or a pouch and they need a lot of hand-holding in that first year, I'm the one doing their surveillance imaging, not medical oncology. That way, there's not a lot of issues with too much seeing physicians and appointments. But nonetheless, that's how I do it. I do think that there are other practices that are just doing strict referrals. And as far as I'm concerned, referring a patient to medical oncology is great. What we don't want is a urologic oncologist that is not referring, is not aware of the literature, and is not doing surveillance imaging in the appropriate way.
Great, thank you. Okay.
And I'm going to chime in and just say, thanks, Trinity. I think I agree with you that we are definitely partners, collaborators, and team-based care. I know that we never lose the urology. I mean, even if patients have metastatic disease, and I don't think it's necessarily a transfer of care. It's collaborative care, and there's still urologic issues, or when patients sometimes still need cystoscopies and things like that. So it really truly is team-based care.
Yeah, and Colleen brings up a good point, because ultimately, we as urologists are where patients are coming through, right? So they identify us as someone that is their quote unquote primary provider, even though we may not be giving them, for example, their systemic therapy. They oftentimes want to know what our opinion is. Well, what do you think? Should I be doing this? And obviously, the answer is yes, of course. But nonetheless, it's our job to work with the patients and our partners in MEDOC and REDUP.
Kristen, I have a question for you. How important is it to provide emotional support and discuss body image changes and sexuality with postoperative patients? I know Trinity addressed it somewhat in an earlier question.
This is very important. Dependent on the patient's goals. There are some patients who are, I'm going to backtrack. I think talking to the patients about what their goals are is going to be one of the first things, because there are some patients who, and I deal mainly with male patients, so I don't have a lot of the female components, but when I talk to the male patients, some of them are very, very happy with their sexuality, even though they may already have erectile dysfunction at baseline. They are very intimate with their spouse. They have lots of intimacy together, but they're perfectly fine with that. They do not have to have any other interventions required in terms of sexuality or with erections. There are some patients who, that's very important to them. Like, that's how they demonstrate love. That's how they feel that they are a man. They're very, their masculinity is sometimes based on their abilities to be able to have an erection. And there are some men who even if they're not in a relationship, even if they are not having any type of a sexual relationship with a person or with somebody, they still want to feel whole. They still want to feel like they are working, and having that ability to have an erection shows them that they are still them. So talking to the patients beforehand, what their expectations are, what they were used to, and what they're hoping to have afterwards is very important. And then also talking to them about it may be very, very different after surgery. Some patients who are having their surgery, like I like to think about it as a mourning process. You know, if you have somebody who is obese, they're smokers or diabetic, like they've gradually lost their erections. They've gradually lost that. But someone who was potent before their surgery and the next day they're not potent, that's a big psychological component for patients to undertake. In addition to learning how to use an appliance, learning how to do CIC or whatever it is that they else need to do, now they're dealing with this, with their manhood, with their self-esteem. So it's something that I am very, very um, aware of and try to talk to patients and their partners with. And also talking to them about the different options that might be available, whether it be, you know, pills, whether it be, you know, vacuum devices, whether it be injections, whether it be, you know, prosthesis, things of that nature. Also talking to them about their body image if they do have a stoma, whether it be a catheterizable stoma, whether it be they're wearing an appliance bag. You know, how do they incorporate that? And talking to the ostomy nurses or having the ostomy nurses there too gives them a lot of information, because sometimes they can have very pretty pouches that they can put on. Sometimes they can put like bandages or like, you know, bands around it so they don't see it. So trying to recognize that this, for most people in my experience, is very, very important, and recognizing it, just hearing them out. Sometimes all they need is just to feel validated with these concerns and figuring out what the best options are. So I think really being a cheerleader, really just listening to their concerns, finding out what their goals are, and how can you try to help them with those goals.
Adele, do you mind if I comment, if that's okay?
Oh, no, go ahead. Absolutely.
So Kristen's like talking about the male patient, and I think it's important that we establish that females or women undergoing radical cystectomy have, you know, quote unquote, complications post-surgery that are related to sexual dysfunction, intimacy, body image, as you described. And what we've learned is that urologic oncologists are not comfortable talking to women about this, and they actually feel like they've never been trained or had the ability to do that. So, you know, I'm in my practice, like I'm very comfortable talking to women about it. I'm very comfortable managing sexual dysfunction in women as well as men post-operatively. And also what we have to acknowledge is that a lot of women will have vaginal complications post-surgery, depending on what operation they have, you know? So we have to be cognizant of that. I'm very cognizant of that in my practice, but all I will say is if a advanced practice provider or urologist or anyone is not comfortable, then find someone in your practice that is and refer the patient and get them help, because women have even more sexual dysfunction. And in women, it's very complex because it's beyond just an orgasm. It has to do with lubrication, atrophy, as well as vaginal complications. So I would just simply say, make sure that you're referring early and often.
Mm-hmm. Great, thank you. Yeah, I mean, each practice should have, you know, someone that can address, you know, these specific issues. So I think that is something to think about, you know, when you're building your team. And Colleen, I think the next question is for you. Here we are. Okay, what clinical signs or symptoms would you consider as a tip-off to engage palliative care or psychosocial support programs for a patient?
Yeah, so I think, like, in my mind, thinking, referring to, you know, options are supportive oncology or, palliative care, social work, psychiatry. I think sometimes it's all, but really looking based upon their signs and symptoms. I think for patients who kind of have those uncontrolled or difficult to control symptoms, whether it be pain, fatigue, anorexia, weight loss, things like that, supportive oncology, palliative care is really, really helpful in managing kind of the chronicity of those ongoing symptoms. So I really like supportive oncology. If it's more like psychosocial symptoms, maybe they're having trouble coping with their recurrence or their newly diagnosed metastases, coupled with, there could be depression or anxiety that comes with that. And fortunately, our treatments have improved. So, these could be years of ongoing emotional support that's needed. So both psychiatry and social work is helpful for that. And I also don't like to forget about the caregivers, because there's a lot they can feel very overwhelmed at times, they help, the patient with whether it be the conduit management, nephrostomy tube management, the bags, the changing, is this okay? Medication management, all of that can be very overwhelming. And I think sometimes the focus always is like on the patient, the patient, the patient. But we really also need to consider the caregiver. So social work is really phenomenal, and I think important for caregivers as well.
Great, thank you. So another question while I have you here, which bladder cancer resources do you find most valuable? And are there specific websites for bladder cancer patients and support groups?
Yeah, so I love Beacon, or the Bladder Cancer
Mhm.
Advocacy Network. I mean, that is my go-to. Hopefully, every patient who's been diagnosed with bladder cancer has been given that as a resource. Beacon.org. Their website's phenomenal. They have tons of information from, being newly diagnosed to risk factors to treatment. They have videos. There will be support for caregivers. They have an online support that patients can reach out. They have survivor to survivor support, as well as recommended local support groups. So Beacon is, again, beacon.org, definitely my go-to. Of course, there's other, websites and support. There's the American Cancer Society, there's the American Bladder Cancer Society. I know a lot of places have their own support groups. Institutions have support groups or ostomy support groups. So those are also really good and valuable for both patients and caregivers.
Great, thank you. And Colleen, there's actually a question in the chat for you.
Okay.
So although it was from the diagnostics section with your great graphic, the question is, can you go back to the high-grade T1 disease, non-muscle invasive bladder cancer, and the likelihood of recurrence of the disease? I think
Yeah, so since the high-grade T1 is so aggressive, even like after the transurethral resection of those tumors, there is about a 70-80% chance that they can recur as another high-grade tumor. And even because they're aggressive, they can then progress into a muscle invasive bladder cancer that happens maybe 30 to 35, 45% of the time.
Great, thank you. Okay. So I think we finally reached our final segment. The final segment is on follow-up and survivorship. Trinity, can you describe the role of the urology advanced practice provider on your team for muscle invasive bladder cancer survivorship practice?
Yeah, I think one of the things that that I've been very fortunate at Penn to have is a group of advanced practice providers and nurses that help me care for my patients or our patients. Obviously, you are part of the group here at Penn that takes care of the bulk of our bladder cancer patients. And I was fortunate enough to be able to work and hire a nurse practitioner who is also a wound ostomy nurse. So I intentionally, sought to have an advanced practice provider that was a wound and ostomy nurse. And also, she is the person that, for example, does intracavernosal injection therapy for erectile dysfunction in my patients. So she does it post prostatectomy and post cystectomy, cystoprostatectomy. So for me, I'm very, very fortunate and privileged to work with nurses and APPs that are catered towards a practice that takes care of patients with urologic oncology, as well as, general urology, as well as things related to complications associated with these horrible surgeries that I perform on patients, So that's something that I think is not present everywhere. And I think if you're able to surround yourself with help, then ultimately the people that win in this is the patients. They're the ones that come out of this with actually just a great experience and come out, frankly, just having a better quality of life. That's been super important for me. And I can't tell you how happy and privileged I am to be able to have colleagues to work with like that.
No, thanks. That's great to hear. Yeah. Okay. Let's see. Now, I believe this question is for Kristen. Let's see, how does your training as advanced practice provider enable you to provide quality care in a urologic oncologic practice with a large survivorship population?
I think coming from for myself, coming from like a nursing background, I think looking at the whole picture of the patient in terms of trying to figure out what's most important to them has been very helpful. I think having the time to be able to meet with patients to discuss some of these intimate concerns is also beneficial. The surgeons that we work with, that we partner with, they have a lot on their plates, as we all do. But they have to see their patients. They're in the operating room. They're doing research. They're doing, training residents. They're in various different parts, and their time is limited. So having an advanced practice or having somebody who's able to deal with some of these survivorship issues, and having that time is able to at least have the patients have a go-to person whenever they have a question, who's maybe a little bit more accessible, not always, but sometimes accessible, via phone call, email, my chart. Partnering with them and having that continuity of care throughout their disease process is a wonderful part of having the training that we have. We're able to see, similar to what Trinity had said, we're able to see them from, the cancer perspective, but also seeing, okay, what are your side effects? What are some things that we can work on? Whether it be with erectile dysfunction, how do we treat you with that? How do we partner with that? And having that go-to person for that patient to reach out to. That's been one of the, definitely the joys for me when I'm working with patients, and also being able to have that partnership with them, seeing how they're progressing, seeing how they're moving forward in their lives. Sometimes they'll come out of surgery, 3 or 4 months later, and they're just miserable. They're just like, sometimes they'll have like decision regret of why they did this. And then seeing them as they progress through their recovery process has been very gratifying. And I think just having that either department or that survivorship role is helpful for the patients, as Trinity mentioned, as also with the providers and also with the other urologists in there as well, where we can actually answer some of these questions in a more timely fashion. So I think it's a win-win situation for everybody.
Okay, great. Okay. All right, so let's see. We have Colleen, can you share your approach for engaging patients to maintain fidelity to their survivorship care plan?
Yeah, I'll weigh in on mine from MedOnc, and then maybe I'll let Kristen and Trinity weigh in. Because, for my patients, they, again, are usually getting referred for, because they have or had muscle invasive disease. So, and could be either, potentially cured or have a locally or metastatic disease. My patients are highly motivated to continue their screening and surveillance and follow-up. And we are usually seeing these patients at least every 3 months with restaging imaging, and that every 3 months is for at least the first 2 years. Obviously, if they have metastatic disease, that's different. But someone who's on surveillance would be seen every 3 months for the first 2 years with restaging CT scan, occasionally a PET scan if necessary, to help us. And lab work, physical exam, and history. So again, from kind of my med-onc perspective in world, highly motivated patients who are very attentive to their follow-up and don't miss. I don't know if Kristen and Trinity want to weigh in from, maybe an earlier stage or what your survivorship might look like.
Yeah, I think from my perspective, some of our patients don't even live close to us, so they have to be engaged. They have to be wanting to coming back to our practice, because we typically like to have the CT scans done or the labs done within the same facility. So having that, kind of keeping them hostage a little bit, because we want to kind of make sure that they are continuing to stay with us during their recovery process. So that can be sometimes a challenge whenever they're like, well, I want to have this done locally at home, or I want to have this done, closer to my house, and trying to make sure that they're making sure that they are kind of coming back to us to have that, us kind of being their quarterback there. And I think also, from like a financial perspective as well, some of these things are very, very expensive for patients, whether it be trying to get medications that may be expensive, whether it be some of their supplies that can be expensive, whether it be catheterizations. Luckily now Medicare pays for most of that stuff, but talking to the patient as well from their financial perspective, like, how much difficulty are you having with any of the things that we're offering you, or that may be prohibiting your ability to move forward with your surveillance. So I think having that connection, kind of keeping them hostage, for lack of a better term, so they can come back to you, and also showing them that the guidelines, or showing them the survivorship surveillance rather from the AUA guidelines, and say, listen, this is why we're doing this. Like, these are the steps that you want to do, and we're the people that's really going to be quarterbacking that with you. So sometimes it can be a challenge, but having that engagement, and many patients, just want to have someone to see every few months, talk to them, reassure them. That's a really good part of it as well, is making sure they're moving in the right direction.
Yeah, I think those are all great points, because we're all very fortunate to work in a tertiary academic center. We get a lot of referrals from, around the mid-Atlantic. So yeah, you're right. We can't have our patients just follow up with us every 3 months. As much as we would like it, it just doesn't happen sometimes. So what I do for my patients, it doesn't matter if they're locally or from a distance. I really, really want to see my patients for those first 12 to 18 months. And I like seeing them every 3 months. Some it's 6 months, some it's 3 months. And as Colleen pointed out, depending on what the cystectomy specimen showed, if they have higher stage disease, lymph node positive disease, obviously we're seeing them a lot more often. They're with med-onc getting adjuvant therapy, right? So, but I like to see them, especially if they have a continent diversion. So I'll spend a couple of minutes just talking about like what the urologist sort of is doing in the postoperative period, and at least what I do in my practice. I like to see them every 3 months. If they have an incontinent diversion or an ileal conduit, like I said, I'm very fortunate to work with someone who's in clinic at the exact same time as me, seeing patients. Janelle Yu is the nurse practitioner that works with me. and she doesn't really work with me. We're partners. And she has a clinic, an independent clinic at the exact same time as mine. But she's a stoma nurse. So she has seen patients that have issues with their appliance. They're having issues with their skin, where they need evaluation. I'm seeing the patients every 3 months to talk about if they have a hernia, a peristomal hernia, how that what effect that has on their appliance application. As you pointed out earlier in the question, I mean, we're looking for upper tract deterioration. Patients can develop strictures, ureteral stricture, which as urologists, it's the sort of dirty little sort of secret or dirty little topic we don't like to talk about. But in reality, it happens in about 10 to 20% of patients that undergo cystectomy. We say it's less than 5 to 10%, but it's actually probably closer to 10 to 15, maybe as high as 20%, depends on your patient population. So as urologists, you need to be seeing them, following their imaging, also following their GFR. As it relates to neobladders, so neobladders, these are patients that are the goal of a patient with a neobladder. The reason why I'm seeing them often is because, number one, they need to be with a pelvic floor physiotherapist. They have to do biofeedback. They have to be meeting with a pelvic floor physical therapist in order to learn how to void to the best of their ability with their new bladder. And I'm seeing them to make sure that they're checking PVRs, to make sure that they're emptying their bladder. If it's necessary, they may need to go back to catheterizing. Once again, looking for upper tract deterioration. Incontinence, both in the way you break down incontinence in neobladder patients is day and night. So for nighttime incontinence, no matter if a urologist is telling a patient with a neobladder that they're going to be dry at night, that urologist is lying, because no one is dry at night. The only time you're dry at night is if you're able to get to about 18 to 24 months post-surgery, and you're setting an alarm to get up to go to the bathroom. Then you can be dry. But otherwise, a lot of patients, don't want to be getting up at night to go to the toilet. So, we're having discussions about their nighttime incontinence, ways to address that, things like condom catheters, things like setting alarms and the like. And then we're also talking about their daytime continence. So I think as it relates to, urologists and postoperative care and quote unquote survivorship, it's about a lot is to do with their urinary reconstruction. And then there's the effects on their metabolic abnormalities. Do they have electrolyte abnormalities? Do they have deficiency in vitamin B12, for example? Are they acidotic? Do they have hyperkalemia? These are all things that happen with patients with urinary diversions, and especially when you're using the ileum. And then lastly, as we've talked about, is sexual recovery in both men and women, how to do that, pharmacotherapy, vaginal estrogen, things like that for men and women. So that's why I personally think the urologist should be involved heavily in that first year to two. And if the urologist is not comfortable doing those things, then I'll say it again, find someone that is in your practice. Because the bladder cancer patients really need that. And Colleen talked about Beacon and how they have the forums there, and the forums are full of everything I just said. I mean, it's unbelievable if you're go and look at Beacon. I mean, it's patients talking about that and actually educating each other and about post-operative care and survivorship. So I just wanted to make that comment. I know we're probably running out on time at this point, but
No, I think we're pretty good on time, and you hit all of the really important points. But since you brought up stricture, I wanted to pose one, additional scenario
Sure.
to you,
Thanks,
Trinity.
Adele.
So if you have, what was that?
Keep it coming. Thank
Keep
you.
it coming. Okay, so if you have a 76-year-old patient, 18 months post-cystectomy and ileal loop diversion, regular interval, elevated creatinine of 1.5 GFR 54, and the cross-sectional imaging shows moderate to severe hydronephrosis at the ureteral-ileal junction on the right side, how would you proceed?
Yeah, so this is you want the board answer, or you want my answer? So first of all, the way I manage unilateral hydronephrosis, you have to think about it is it a recurrence or is it a stricture? Okay, so strictures occur. The time frame for stricture development, ischemic strictures, is somewhere in the order of 10 to 18 months, about a year to two. Okay, now you can still get strictures 10 years later, but that's when they happen. Okay, it's oftentimes left, not right. And the reason why it's on the left side is because that's where you're bringing the left ureter underneath the colon. You've got more ischemia, compression. The left ureter is oftentimes longer because it doesn't, you got to bring it to the right side to anastomose to the ileum. So for me, I look at that and say, okay, I look at the path and I say, did the patient have CIS in the path? If they had CIS in the path, and especially if they had a positive margin at that ureter, I'm thinking, well, this might be recurrence. So I'm going to be a lot more proactive with investigating that. If the patient is asymptomatic, doesn't have signs of infection, pyelonephritis, urinary tract infection, they are not in pain, and their GFR and creatinine is stable-ish, I'm getting an interval imaging within 3 months, 3 months later, and I'm telling the patient, I'm not ignoring this, but I don't want to go down the road of, guess what? You need a nephrostomy tube. You then have to go to IR. You then have a tube in your back. We then have to go down, do potentially endoscopic management because it's the art of medicine. There are lots of patients with unilateral hydro, stable creatinine, asymptomatic, not having infections that we observe. Because let me tell you, so patients are not happy when they have tubes in their back and they're having to come back multiple times for different procedures. I'll just briefly say endoscopic management of ureteral stricture is really, it fails the majority of the time unless it's a short stricture. So you essentially are going down a road or a path where this patient may be going towards, endoscopic repair, maybe even open ureteral reimplant or however your urologist does it. So I'm very conservative. If I think it's a recurrence, then I'm a lot more proactive. And if the patient is symptomatic, pain, infection, drop in their GFR, increase in their creatinine with that CT finding, then I'm being more proactive.
Great, thanks. And we do see some of those in our practice from time to time, so.
What do you mean? It happens all the time. And if you're saying it doesn't happen, then you're not doing cystectomies, period. Okay. Sorry, I just have to say it.
Yep, no, we see them. Since we're on the survivorship segment, I thought I'd wrap up with one question, and any faculty can answer this question. Does your practice have specific clinical pathways for bladder cancer survivorship? And anyone can take that question.
Colleen, why don't you do it? You're at a much better cancer center than ours.
So, I mean, I will say, in medical oncology, we don't have any specific survivorship pathways. Our urology team that has a specific designated survivorship clinic, they have, a specific clinic and then pathways that they follow. Again, I think just probably because I'm on the med-onc side, seeing mainly metastatic patients, we don't have that specifically, but our urology team does.
Kristen, how about at your place?
We don't have a set program, but what we do is, we work with the individual urologist who's managing the patient along with the medical oncologist. And we're also looking at the NCCN and we're also looking at the AUN guidelines. So we're looking at all these different things together and kind of like using them synergistically and, working with the med-onc and also working with urology. So it's very patient tailored, but it's not a one step program. Very flexible.
Great, thank you. Okay, all right, well, I think we're nearing the end. Is there anything anyone would like to add, or
Yeah,
is there, again,
I'm sorry, Del. I think one thing that I'd like to sort of bring up because of, I think we have been talking a lot about cystectomy and the issues related around cystectomy, but there are patients that are that desire bladder preservation, and I think that there are some really outstanding clinical trials that are looking at the role of systemic therapies and then observation of patients that have a clinical response. And I think the future of our field is going to be ways to preserve bladders to prevent all of these, kind of very, very, diverse and complications that we're talking about. Cystectomy is a wonderful way to treat bladder cancer, and it's highly effective. However, it does have some downsides, which we've been discussing. So I think the future is bladder preservation. And right now, you can do, trimodal therapy, chemoradiotherapy, and select patients that meet the criteria, which is essentially solitary, mostly solitary muscle-invasive disease, no CIS, no hydronephrosis, with a functional bladder, right? The problem is that's not the average muscle-invasive bladder cancer patient, right? So unfortunately, it doesn't fit everyone. So one size doesn't fit all. And I think what we're going to see over the next coming years is a lot of work looking at bladder preservation, which is already happening and has been happening for like 5 to 8 years. We just haven't gotten there yet.
Absolutely. Well, this was a fabulous discussion, and I hope the audience enjoyed it as much as we did. So this concludes our program today. You may now go to the AUA University and claim CME. Thank you all for joining us.